introducing chiropractor Ashraf Ali or his CPD event. Ashraf, what are you talking about today?
We're talking about lower limb injuries, specific to gymnastics, but you can use it on any athletes or anyone with any kind of lower extremity pain. So summary of the approach, first of all, really important to know the anatomy, and then it gets to a point where it doesn't matter when you're rehabbing and so on, but it's important to sort of see what's affected in which plane, especially for the hip, because there's so many structures around it in terms of the capsule, the labrum, and all the soft tissue. So yeah, that's it really. In terms of something I've really learned from here, which should be sort of obvious, to test upstream and downstream, sort of kind of take, like, say, the knee. Okay, the knee might be tricky because you might need to do upstream and downstream, but it kind of carries over, especially with such high performing athletes that are doing backflips and round offs and all sorts of stuff. But yeah, check the range of motion, overpressure for ligaments and the joints, then muscle tests, and that's it.
As you say, check upstream, downstream, above and below.
That's it, yeah. So if it's a hip, maybe check lower back because it's so sort of closely involved, then maybe the knee, or if it's the ankle, then check the knee. But yeah, and the thing is, later on we talk about some maintenance care, so people coming in for checkups and so on, then you can kind of just do some orthopedic tests to make sure nothing's creeping up or anything like that. But yeah, so rules of thumb for working with athletes is checking the workload and how it's spiked. So with gymnastics, when athletes are learning new skills, sometimes if the programming isn't quite on point, you might be sort of inclined to maybe, I don't know, like absorb more impact or really sort of go into extreme ranges of motion, which is massive for the hip. So a little bit about the hip, right? So kind of got the, obviously, ball and socket here. And when gymnasts go into sort of split pelvis positions, it can kind of subluxate and come down, which is fine and it's normal, but you've got to make sure they're not kind of overloading it. It's like essentially like a bicep curl. If you learn a new bicep curl, you're not going to use the normal weight you use for anything else. But yeah, younger athletes, growth plates are super important because they're essentially another insertion of structures because it hasn't properly developed. So I guess it's like a myotendinous junction or a bit of cartilage and stuff like that. And yeah, understand the athlete and the environment they're in. So we're talking how the parents interact with the environment, coaches, any other practitioners they're seeing, because I'm quite alien to the sort of whole gymnastics setup. But from the David Tilley's course, he was mentioning that there's a bit of a, how I sort of interpreted it, is a bit of a meathead mentality. So my background's in obviously powerlifting. And it was like, oh yeah, I'm just going to grind through this. And I thought that was very specific to that. But it kind of goes across all sports, especially cheer and gymnastics, because you're learning new sports, you've got deadlines, you've got the season ending, you've got to make some comps and so on. So that's really important as to what they're feeling. So if like an athlete comes in with a parent who's speaking more and try and like guide that sort of consultation towards specific to the athlete, it could be a case of, oh, the athlete wants to hang up their, I guess, gymnastic shoes or something. But the parents are really sort of determined to sort of get them to the next level. This is it. There might be some of their ego playing into it rather than something they take them to. But yeah, that whole idea of like patient-centered care is super important in athletes that's pushed quite a lot. So yeah, with the assessment, there's obviously 3 areas: hip, knee, and ankle. You do kind of a global evaluation of areas as well, just to see how things are going, if there's any compensation or so on. But I personally believe you've got to kind of take it with a pinch of salt because we are human, right? So there's not sort of objective measures telling you, okay, so thoracic's rotated 50% and then the lumbar's rotating more or whatnot. So yeah, that's super important. So for the global assessment, what we're going to do is, so I'll show myself, and then for the bench stuff, I'll just get someone up for space. So first of all, it's just going to be just range of motion, so bending down and touching your toes, but changing the width as well, because the further out you are, less of the spine is involved and you're more inclined to use the hips, because I'll speak about it a bit later, but the hips are a bit of an angle, but yeah, I'll speak about that later. So there's more hips here, there's less hip here, and as you can notice, I can go not as far, purely because I've got hip pathology, but yeah. And then extension, so hands on hips, coming back, and then maybe, I'll tuck my shirt in. Exposed to public and all that. Okay, and then you're gonna sort of lean back and see if the hips translate quite far forward or not. So if you're kind of lacking an extension, okay, there's a little bit coming, sure, but if you're really lacking extension, you might just go from the hips. So if I just extend my hips, okay, I'm here, and that's just purely hips, and that can compensate through that. So that can translate into any kind of landing positions, any running positions, and so on. And then just simple sort of biomechanical analysis, I guess. Squat, so seeing what's comfortable for them first, and really seeing if they can really narrow the stance and see what creeps up. And throughout that, obviously, you're going to be checking if, I don't know, if there's any pain coming up, if there's any kind of symptoms they've been noticing, or some sort of niggle they've had and they've kind of worked through. And then a lunge, and that can be important for any adductor pathology, which is quite new to me actually, because the adductors aren't just purely for adducting, they flex and extend the hip as well. So if it's a back leg, is that the extension of the hip causing that? Or is it the front adductors kind of flexing and so on? And then you go into just a single leg squat, seeing how low they can get, and seeing if that kind of goes into it. I just wanted to throw kind of this back at you a little bit. What's normal for an athlete? I think I'll put it in later, but I think it kind of works here. How do you know what's normal for an athlete and what's dysfunctional? Like, where do you draw that line as to, okay, they haven't got any pain, but they want to obviously perform as best they can. Where do you go from there? Okay, so let's talk landing, for example, right? If I'm landing like this, and I'm, I don't know, best in the country, yada, yada, yada. Do you mess with that, or do you let it happen? And are you doing a disservice by letting that happen in case there's an injury in the future?
Pain for me, we want to give this factors. You're saying in the absence of pain, I'll probably just go towards what I know might be a risk factor. So for a gymnast, if they don't have at least 10 degrees of dorsiflexion, if they're habitually landing with more of a valgus, strain on the knees, if the hip extension is too shallow, that's what I might start to look at. Is that pretty
Should have given you the mic, sorry. Should have given you the mic, sorry. Yeah, that's a good point. It's just, it was a thought that came to me, and I was kind of, I think I had a chat with you about it as well, like the level of stiffness someone's feeling. So obviously, classically, we're kind of taught to really feel the muscle, or that feels tight in there, and telling people, or do you wait for that feedback to come back to you? And then how do you know what works best? Because if you change the technique, you're going to have to wait a couple of months for it to see if it helps and so on. Yeah, back to the analysis. So it's going to be a simple sort of pogo hop, and then hopping on the spot, and then single leg hopping. And then what you can do is kind of really land, and then turning as well. So that can be massive for the knees because of the valgus and varus stress. Because if you turn this way, there's valgus here, varus here. So just to see whether they are just caving and that's causing that meniscal compression or MCL sort of irritation. But yeah, with regards to the hip, there's actually not a massive amount of usage rather than the range of motion, because a lot of the time it's quite shallow, but there's still a lot of force going through the joint because obviously it's kind of still hitting the leg, because they're landing from quite high, I guess, heights, I guess. And gymnasts use their legs as arms, pretty much. like they can sort of get their legs sort of at head height and so on. So it's super important to see what normal is for them and kind of work off of that, and obviously talk about what's subjective and then sort of take any objective measures. Yeah, so the hip, yes. So this was mind blowing for me. I should have really known this, but anyway. So the labrum, okay, so sorry, the acetabulum is actually at a 45-degree angle tilt. So that can obviously allow you to flex and extend, but that abduction has actually got like a bony block. But obviously if you go quite far, you can subluxate it till, later on. And if it's a normal thing for a gymnast to do, then you've just got to train it with Cossacks. Oh yeah, you do Cossacks in the evaluation as well, which makes sense, I suppose. And yeah, so video, just kind of drop them down. Been practicing. Yeah, Beighton scores. It's really important. So gymnasts are flexible. Sorry, Beighton score.
Oh yeah.
So yeah, out of 9, you'll be checking if the thumb can touch the forearm. 1 for each. 1 for the pinky. 1 for each arm. Knees extending, and then being able to touch touch the floor. Sorry?
At least an 8 then.
Nah, I've got 4. Nah, not these. Yeah, they extend. But nah, maybe.
That is 100%.
Yeah, we're gonna have to get the goniometer out of that. Maybe not, or maybe.
That definitely.
5. I'll give you 5. So past 90, I think. Or is it 90?
Oh, look at that.
Oh my god.
That's
No way.
That's normal.
I was like, wow, that's so stupid. That's not what it is.
Fair. I thought it was all the way up here, but fair enough. Well, newsflash. But yeah, so it can be linked with hip dysplasia, and obviously capsule laxity can be, I guess, disposing you to various conditions and so on, especially if you're getting into those extreme ranges of motion. Another thing about stretching methods, there's a lot of extreme stretching methods used in gymnastics apparently. So you've got to make sure the technique they're using isn't so aggressive, because you've got to trust the tissue is going to go. Because if you keep yanking it, it's going to get angry. So yeah. Yeah, so if they've got low range of motion and Beighton score, a high Beighton score above 7, then do soft tissue testing, because a lot of sort of hyper mobile athletes or people, they tend to get a lot of muscle tightness, especially if they haven't got the range of motion, which is a bit odd to me, because if you're lax in capsules, but
She's saying that the muscles compensate by shortening.
yeah, exactly. Yeah. That makes sense, I suppose. Yeah, so you would do. Actually, can I have a hip, please? Please. What? Okay.
Lizzie, you got to take some pictures. What's the?
Could you lay on your back for me, please? Okay, so you check. Let me on that side. Okay, so obviously we'll just check range of motion, just kind of going into flexion, and then checking internal rotation and external rotation. If there's any capsule involvement, what you might find, they don't really like doing this repeatedly. So you might want to just check, just going back and forth, just to see. Because I have that, so because I've got a cam impingement, I can kind of firm it going through here, and then like my body just says, up, 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 just don't go there. So what you might find is you're kind of coming round and coming here. So this, because obviously you're stressing the anterior medial capsule. But yeah, that will kind of go along with all the assessment in a minute. Another thing that was really sort of eye-opening for me. So Faber test, because obviously that's flexion, abduction, and external rotation. So just like so. So smash and score, nice. So if their range of motion is okay, but if Charlotte's sort of up here, then you can check if the core is involved and if that pelvic position can affect it. So David said you've got to have 2 people doing that. Sounds a bit faffy, so I improvised. Okay, so what you do, okay, just drop your leg for me. Okay, if you could do that for me. That's it, yeah. So what we're going to do is just let that drop, and then it's going to push into my arm here, like so. And see if that changes it. See if we need to kind of train the core a little bit, sort of according to that. If like you've got a sore shoulder or something, you can just like put your back there, and they'll just push on your back.
What would you see if the core was involved? That you would go lower?
Yeah, so it just opens that capsule up because the core is engaging essentially. In terms of, so what we'll do is, sorry Liz, can I have leg side please? You just, oh, no, other way, and then down. Okay, cool, cheers. Right, so what we can do, so you can pop that down. So what we can do is kind of do a screen for the hip. So this is a bit disjointed in terms of positions, but what I wanted to do is separate different areas so that we can actually see how the tests kind of link up. So first one is just a supine leg roll, and you're just going to roll the leg. Any pain? No? Feeling good?
Yeah.
So that should be normally pretty comfortable, but if they've got a really irritated capsule, that can be a bit of a problem. Would you mind going in front for me, please? Cool. Right, disclaimer, I don't like this test because, okay, so what I'll show you, so this is Craig's test, okay, so I'm just going to bend this knee here, and what we do is palpate for the greater trochanter, and this is a screen for any hip dysplasia. So the idea is, if it's a normally placed hip, it should be between 8 and 13 degrees, you should be able to feel the trochanter. If it goes any further than that, okay, I think that's retroversion. This is anteversion. Personally, it's such a small range, so pop it down for me, thank you. It's such a small range, it's hard to be sort of specific with it. If it's very obvious, you can catch it. I guess getting a goniometer and stuff, but I'm struggling with it, if I'm honest with you.
So if you went like that way, you wouldn't feel it anymore?
Yeah, so yeah, if you went too far and you still felt the trochanter, it should kind of drop off as you get further into internal rotation.
Oh, okay.
So yeah, if it's not within that range, then that's a bit of an issue. Whilst you're there, we're just going to test the capsule. So what we're going to do, so this position is a figure of 4. So as you can see, that's going to be sort of anterior, sort of inferior medial sort of thing. So if you could go into a figure of 4 position for me, Charlotte. That's it, yeah. So just bring that knee up for me. That's it. So I'm just going to just push down and forward up on your glutes. Is that okay? Cool. So we're just going to just push and really sort of kind of enhance that fulcrum position in the joint just to see if that's causing any pain. Yeah, essentially, but it's, I guess it's still doing the same thing, yeah, but it's more superior.
You get more PA.
Yeah. Exactly. It's a bit more superior as well.
Oh, that's where you're on. Okay.
Yeah, because it's more about the labrum rather than the sort of laxity. Could you go on your back for me, please?
That's the oldest sleeping position.
Oh, yes.
Yeah. Best way to sleep. I did actually feel something in that one that I've never felt before.
It is an odd position. Like, it's that idea again, like, should you be okay? Like, if you were a gymnast, then yeah, we kind of need to work on it. But if you're not getting your leg up in this position, like running and sort of doing tricks, then should be okay. Cool. So obviously we've got the Thomas test, and this was interesting. Okay, so what we're going to do is bring one leg up. So this takes out the pelvis in terms of when we're testing the hip, because there's none of that sort of shear onto the pelvis. So if you could just hug this knee for me. Okay, so what we're going to do is come up, and then we're just going to do a simple fadir. and then we're just going to actually compress and then externally rotate. How's that feeling? You all right?
Yeah, I can feel a bit of like compression in the back, but not in my groin.
That's good. So it should really just push on the posterior capsule there. That's called a Dixery. So it's just acronym for dynamic internal rotation for deer, basically. Cool. Could you lay on your side for me, please? Face that way, please. Yeah. So same idea again. We're just gonna bring this part of bring that knee up for me, and if you could just hug that bottom leg for me. So this is that fulcrum position again. So what we're gonna do is let's just bend this knee for me. Cool. Just gonna just bring this up, and then we're just gonna apply hyperextension, and that's purely just basically hip flexor stretch, but you're kind of just applying overpressure for the capsule. Okay, and then what you can do is kind of bring it round and then apply pressure again. So that's more sort of medial inferior capsule rather than anterior capsule, pretty much. Okay, could you go on your back for me, please? Cool. So scowl test. That's just to screen the capsule again. So what we're going to do is just going to bring that leg up and then just sort of go in a figure of 8 to kind of scan out the capsule. So that can kind of guide where you're going. And then obviously for deer, and then going into external and coming round. I think that's a deery. So it's internal rotation, impingement test, basically. Let me just check if I'm missing anything.
Checking internal rotation, trying to angle with hip flexion.
Essentially, yeah, just like stretching the capsule from different angles so that you're not kind of missing anything.
How do you know if it's definitely the capsule that you get? Like, because if you're in that position, you might have like adductors or something that are a bit sore. Then
yeah, so what you do is muscle tests in that kind of position as well.
Okay.
So because the ligaments kind of, from what I understand anyway, the ligaments sort of sit under the sort of muscular system, I guess, because of all the tendons and so on. Then you just overpressure to see how it feels. But yeah, there is going to be overlap for sure. But it's just to kind of increase the likelihood of one over the other, really. So cool. So as you're in that position there, so Thomas test. You kind of actually, let's do the Thomas test because there's a few things that I didn't know about actually. Could you sit on the end of the bench, please? Cool. Cool. Right. So with the Thomas test, you're kind of in that sort of extended position. So what you can do, obviously, check for rec fem, check for quads, check for hip flexors, and then you can check that anterior capsule again. So there's a lot of capsule tests, especially for the anterior. So just be careful. If you found like maybe a couple, maybe 3, stop there because it can obviously be quite sore. Yeah, I guess we'll just show that quickly. So Thomas test. So what you want, if you just jump up for me. So what you want to do is kind of sit at the end of the bench, hug the knee. Actually, you can just do the test now. So as you can see, like my knee is very extended here. So that's a bit more sort of quadriceps rec fem kind of, I guess, tightness. And then if you apply overpressure from my foot, that's it, and see if that fulcrum mechanism plays into it. So there's no pain there. Then you can do the same thing, but from the knee. That's it. Nice. That's it. Thank you. Exactly, yeah. So you do it knee, then shin, just to make sure that you're not kind of doing something that's more irritative than not. If that makes sense. So with the medial hip, there's Fadir again, there's Diri, so kind of that actual compression and internal rotation, and then seeing if you can kind of bring it out again. So that's why that's why you do a few of them to see if there's overlap. And then Thomas tests, obviously from sensitivity and specificity stance, It's not great, but it can help build a nice picture, I suppose. Okay, cool. Okay, so yep, fulcrum tests. We've just done that. This was interesting. If you lay on your side facing that way, please. Okay, right. So in terms of testing adductors, I've always tested adductors supine, sort of arms across, but you can just check it in Copenhagen and then kind of see if the sort of, I guess, magnus and longus, I believe, the hip flexors as well, they are kind of playing into it. So what we'll do, if you just bend your knee and just lift your knee up for me, there you go. And I'm just going to put my hand under there and just push down. How's that?
Yeah.
Cool, sweet. So ideally, you want to start from an extended position and then push down. And then we're going to go into sort of flexion. So keep pushing down, keep pushing down, keep pushing down. How's that? You okay?
Yeah.
Cool. So if that's okay, then you just test with a sort of pressure on the foot, pretty much. With a lateral hip, it's pretty much similar. So you do the fulcrum test anyway, but just checking glute med, glute min, and so on. Am I missing anything? From the examination? Mm-hmm. Yeah.
I think that longus and magnus are extensors. I think they're part of the hamstring.
Oh, okay.
I'll check it.
Yeah, that makes sense because longus is a lot longer, so it can.
Yeah, and also they
extend.
sit more posteriorly. Brevis and then pectineus and
Yeah.
There's one more. I think they sit more anteriorly.
Yeah, that makes sense. To be fair. Cool. So posterior hip, Faber test, because it's kind of causing that contracture of the external rotators. SLR was massive actually, so which is something I found out. If you lay on your back for me. So SLR, we know, checking for discs and so on. So you just lift the leg up, obviously. Should have warmed up for this. Okay, right, just relax for me. So obviously coming up, okay, there's an ouchie potentially, okay? And then what we do is dorsiflex, see if there's nerve involvement, and there is. Then what we can do is get you to hold it, and then we push up. How does that feel? So it's testing the anterior capsule again, or you can just push down and see how that feels. So that'd be more hamstring, so proximal hamstrings. Or what you can do is test the hamstring length. Yeah. I need to do it from here. My shoulder's going to go. So, yeah, so there. And then just get them to pull down just to see if it's proximal hamstring and so on. That was massive because I kind of just isolated SLR to maybe hamstring, something's funny's going on, discs involved, but obviously there's a lot more to the picture usually.
Where would you expect any pain with that one?
You could get it in the hamstring. If it's in the calf, then it's maybe a bit more nerve involvement, depending on what part. So if there's dorsiflexion, you've got pain, then it might be some sort of nerve involvement. If it's kind of belly of the hamstring, then you do a muscle test to see.
What about for hip?
For hip,
Anywhere in the hip?
yeah, I guess anterior hip, I would have thought. If it's posterior hip, then I'd imagine maybe a stretch on the sort of glutes.
Okay.
So then maybe do a bit more of a posterior capsule analysis, I guess. But that was the biggest thing for posterior hip. Never thought to sort of use SLR across different areas. A lot of this, obviously, as you can imagine, it kind of tests the groin, the musculature, ligaments, and so on. So it's super important. Just a moment. Cool. Right, if you have a seat for me, just facing that way. Cool. Hamstrings, obviously pulling back. So if you pull back for me, nice. So this is where how specific do you need to be kind of comes in. So he speaks about kind of internally rotating and then pulling. So
much more that immediately.
yeah. So it's that pedanserine sort of tendon, right? And then coming out here, so that'd be more bicep fem and pulling back. And whether it matters or not, because the thing is, you're still just going to rehab the hamstring. So maybe it's for sort of reports and so on. This is where like the medical culture, like it differs from America to here.
Specificity.
Yeah, in terms of like how involved we are as well. Because even though, like, if we were in America, even though we're private, we're kind of working with doctors and so on. Whereas, kind of like the communication between GPs and us, it's not massive. We send them like letters and so on for referral, but that's kind of as far as it goes. It's not like any feedback coming to us. So, yeah, it's good to test it, especially if it's like a knee pain issue. But I guess you could still do it because whilst you're there, it takes maybe a second longer. So yeah, So there's an idea of dynamic testing, so slumps tests, lumbar referrals, just to make sure it's not anything sort of that might take a bit longer to sort out, or you need to kind of wait for the natural history to calm it down. Link it to skills. So what are they looking to do? What are they learning? How can you break it down so they can still work around it? So if I'm doing, I don't know, a cartwheel, that's as far as my gymnastics skill go, right? And that landing is painful. We could still do any sort of overhead movements, kind of making sure we can kind of land on one hand, just so you can transition. So yeah, working around that injury is super important. Trendelenburg and some of that dynamic assessment from earlier. So the pogo hops, single leg hops, super important. Looking at landing technique and so on. Cool. Thank you for your hip. Cool. Oh, before you go, could you lay on your back for me? This is awesome, actually. I'd never thought about this for hernias. So you get the patient in like half hook line supine. So if you just bend this knee for me, and then you just do a curl up. If you've got like kind of hernia kind of area pain, so curl up is in like coming up, that should kind of bring it up. So I didn't know of a test for that. So yeah, so you know, I suppose. Like you said, is this very thorough, like more thorough than some people would? I don't know if I'd use all these tests though. It's about weaving into what's like happening and whether you go down the route of, oh, what's the root cause, or okay, what's affected? Let's kind of work on it. So that's an internal crisis for everyone to have. Cool. Thank you, mate.
Thank you.
Cool. Knees. Okay, so obviously we're further down. So there's a lot more happening in terms of absorption of like forces. There needs to be some sort of ability to translate. So what do you train in valgus to make sure if you fall into valgus, it's like doing a J curl for deadlifts, right? Do you make sure you're exposed to it so you're not kind of overwhelmed by it or not? So that's something you need to sort of work through, I guess. As far as it goes with the knees, it kind of is the same thing. I mean, knees. So David Tilley made knees so complicated, and I had to watch the video like 3 times. And I still don't quite understand it, right? So the mechanics of the meniscus, and he was throwing up diagrams that I still don't understand it, and how they kind of interact with each other, and how the angles of the meniscus kind of sit on top of each other. What I took from it, I guess, is the knees inflection, posterior, extension, more anterior. That's as far as I got.
So we do kind of use that in our McMurray's test.
Mm-hmm.
So I think when you look at McMurray's test, you are looking to posteriorize the meniscus and then compress it on the affected side.
Mm-hmm.
So, for example, I think is that what McMurray's test? So if you were to flex, and internally rotate and compress, you're more likely to hit the posterior horn of the medial meniscus, and then vice versa for the lateral meniscus.
Yeah.
So we do kind of use those mechanics in our testing.
Absolutely. It's just doesn't matter.
Does it matter? Well, I think for testing it might give us a little bit more clarity. I think, like you mentioned, it might give us that.
Sorry.
No, I'm saying it might give us that, for the lack of a better term, clout when we're trying to communicate to our patients. So, like, for example, I've been in situations where that test has come in very useful, and the patient has either said, it's funny you say that, the MRI showed, or they might then get a test and say, the MRI showed exactly what you thought it would.
Yeah.
And that might give the patient a bit more confidence in what you're thinking, but what makes sense. Oh, yeah. Yeah.
Oh, nice.
The audience.
Yeah.
Start making fart sounds while you're talking.
It's not like you.
How do I turn this off? There you go. So I'll put it back on. Yeah, I'll put it back on.
But yeah, I wish, right? This is on my like Christmas wish list, I guess, as a practitioner. If we could find out whether the midline meniscus is affected rather than, I guess, outer meniscus, I guess, is affected, that would change like our prognosis rates and like the accuracy of it massively. But I guess it's pretty much impossible to do that because it's always kind of affected, so it's hard to take pressure off that, I guess.
The only influence factor I would have might be pain, because on the midline that's red zone. Is that right? Red zone is internal.
Yeah.
Yeah. So therefore, they'd be more likely to experience pain with their dysfunction.
Okay.
And if it's on the outskirt, outside of the red zone, they're less likely to experience pain. Injury. The way that I might educate a patient is if they're looking for surgery and it's the red zone that's affected, the recovery is going to be much more painful.
Mm-hmm.
If they go for, say, meniscus repair,
yeah,
in comparison to the outside.
Yeah. But yeah, they're spot on though, but pain's so complicated.
Yeah, I'm not saying
no. I know you know that obviously, but it's, I don't know, just like little kid in me just wants midline meniscus tests, I guess. Not really, because it's so dependent on like mode of injury and so on. It was just that it has a worse blood supply, so you can't expect a quick recovery. But then like the type of tear is effective as well. So like radial tears kind of affect everything. Then would you get function back quicker than like circumferential? That one. Yeah. That across there. So I guess it's like a bit of anatomy for us to like just think over, but does it matter? The age-old question. Sorry. All right, cool. Can I have a knee, please? Who wants to give me a knee? Yeah. Oh no, it's fine. You're good like you are if you want.
You can do both sides.
I'll just do left. It's fine. Cool. So. Yes, please. Yeah. Cool. So with the global assessment from earlier, you kind of test the knee whilst testing the ankle and the hip anyway. One thing that was cool, this was like something I had to use, I guess, my understanding of mechanics until someone just said like, oh, look, if you have pain during a Faber test, it's some meniscal irritation. But I don't know, me personally, I'm very tough to be like, okay, this is a hard and fast rule. But yeah, Faber test, knee pain, maybe meniscus. But yeah, checking range of motion. So what we would do, so we go. Cool. It's just if you're doing a screen, just checking upstream and downstream. If it's kind of happening, then yeah, maybe. But obviously, you'd have McMurray's test and so on to kind of confirm, I suppose. From what I remember, I don't think there's anything specifically new from kind of what we probably do. So kind of obviously range of motion, kind of extending and seeing if there's hyperextension. Just maybe get a block under there or something to see if there's hyperextending. Internal and external rotation, and then just doing strength testing, obviously. Seeing if the actual person can do it. Actually, he does it seated, but this was like literally a force of habit of just doing it supine. But yeah, seated works really well because you can really go far into it rather than... Yeah, exactly. Yeah, instead of like having to be like, okay, am I pushing enough? Like, does that hurt? Then obviously ACL, PCL. So just doing some draw tests, like so. You can isolate the medial and lateral ACL and PCL by just internally rotating the tibia and then pushing on the outside, and then externally rotating on the inside and hitting it like so. PCL, same thing. McMurray's, like you said. So that is kind of, okay, let me know if that's okay. Thank you. Okay, so externally rotating, pushing in, anterior meniscus, posterior meniscus. I never thought like that. That's genius. I never put it together because you were like, no, in terms of the meniscus, but nice. Yeah, and with MCL and PCL, so I'm just going to do it from the top here. So say if we're doing LCL, so it's going to just straighten the leg here, and then that is testing, I guess, the joint and any irritation from the joint. Then coming up to 30 degrees, just kind of testing any varus from there to see if there's any joint laxity there. It's a bit like the pivot test, where you kind of do ACL and MCL together and kind of go around there. Just standard stuff like sag signs. So getting the patient to kind of bend their knee. Okay, we get both down and see if there's a sag sign from the lateral femoral condyle and the tibial tuberosity. If it's increased in terms of distance, or if it's different to the pain-free side, there might be a PCL tear or strain, I suppose. That's it, really. That's the knee. Let me just check if I've missed anything. I don't think I have. Pretty much, yeah. Because standing meniscal compression test, that was massive. It's good, isn't it? Because you can get nice. Yeah, because you use. Yeah, because like you can just get them to sort of bend the knee and kind of come in and then out. Make sure you support them because I fell over a couple of times. I had to practice it last night. I literally had to. Yeah. Yeah, that's pretty much it. And it's just testing. The knee's like very sort of biomechanical in a way. Like, okay, it got anterior, posterior, lateral, medial.
It's a bit easier, isn't it?
Yeah. It can just be a bit trickier when it's like kind of like just diffuse pain, but then you just got to wait for it to calm down and work around it. But yeah, thank you for your knee. So ankles. So yeah, obviously they're kind of like the hands of the legs, I guess. You're kind of taking a lot of impact. You're kind of asking for a lot of like stiffness from the Achilles, but a lot of flexibility as well if you're a gymnast, seeing where you want to land, and especially how they're expected to land. So this is a big sort of thing in gymnastics, I guess, like sort of landing kind of feet together and knees planted and kind of obviously flourish and whatever. But yeah, I don't know, it's from PE. Yeah, cool. Shout out Mr. Gray. Okay, so obviously proper landing techniques are kind of like plieing. So as long as you can touch your sort of heels together, that should kind of be where you're at. But that's about the scoring and the intricacy of the gymnastics. But let's have an ankle, please. Cool. So, just loads of bones, loads of joints in the ankle. Just going to test active range of motion. So, pointing the toes towards you, Elliot. And then down, please. And then sort of bottom of your feet kind of facing each other. That's it. And then out, please. Lovely. Very good ankles here. So, can give you a nice screen as to what can be causing pain. Obviously, active range of motion is a lot involved. So, just relax your feet for me. Thank you. Just checking passive range of motion and then resisted range of motion. So just hold that there for me. Lovely. And then push down. Lovely. And then hold that there for me. So in, please. There you go. That's it. Hold it there. That's it. And then out, please. Thank you. And hold it there. And sit relax for me. One thing I learned from Elliot, shout out to Elliot, testing flexors of the toes, kind of just gripping it like that, and then just getting them to push down, like so, and then test the big toe. Huh? Where? There?
Yeah.
Okay.
Oh no, it's fine now. It's all good.
Yeah?
Yeah, it's all good.
Okay, cool. Right, and then what else you can do is just check joint play, just of all the joints, and that can be your ligament test as well. So, okay, so plantar flexion and inversion, anterior ATFL, and then just going into a little bit more neutral position, and then pulling is PTFL, and then calcaneal fibula. Yes, am I right? Yep, cool. And then just testing posterior tunnel, obviously. What I found is just checking like how all the different bones are feeling is really important. Just kind of like cuboid and kind of working around. Just light mobilization can actually work wonders for some people. Pretty much it. Then with the ankles, you just want to see when you've got pain. So Dave Tilley uses dynamometers. I keep forgetting to grab the dynamometer. But every time you test it, you have specific numbers. But that would be really important, especially for gymnasts. So, Elliot, could you stand up for me? So, check in sort of calf raises, see how that's feeling, and then relax for me. And then obviously we check single leg as well, and then sort of bent knee calf raise, and that's it. Coming up, lovely. But yeah, just checking the different muscles and so on, and how there is pain, when there is pain, and then just actively checking it as well. So single leg balance is really important, and actually just bouncing on that foot is really important. Oh, back to back, nice. Let's get some turns in. So jump and turn. Nice, look at that. Sweet, thank you. I believe so. Please, yeah.
So I did a course with an ankle physio, and she showed us some really good tests.
Mm-hmm.
The first one is a standing test, and it's for foot strength. So is there a bit of scrap paper?
Any paper?
Is it? No, it needs to be paper. Is that right? Yeah, that should be fine. And then you just place
it nice, yeah.
under the foot.
Yeah.
And then you put your foot down, and then hold on, lift your foot up a sec. And then what you want to do is I'm going to try and pull the paper away, and you're cheating. So what you need to do is keep your toes straight, and so instead of clawing them, you keep them flat, but you don't let me pull the paper out. Yeah. And the idea is really you're looking at the big toe, but you don't want to be able to pull that out. And quite often if they've got weakness, you'll be able to just pull the paper straight out. And that's just a really good one that you can obviously objectively test when they come back in as well. Cool. The second thing was that she said if you lay on your back, you know how you did the resistance of the toes, just straighten your knees out for me. And you did like all of them. She would directly just do the big toe as well, so she would literally pull it right up like this, and then you push just the big toe down, and you just test the strength that way.
That's a good idea.
And you would do that both sides.
Mm-hmm.
And then just the other really good takeaway is that, I mean, we all probably give calf raises for like any foot and ankle stuff, it's really good. But she said when you do the calf raises, elevate the toes just slightly with a rolled up towel.
Better for plantar fasciitis.
And it
She's
will
saying all issues.
mainly for plantar fasciitis, but you can, depending on what it is, and just having the toes like elevated even by about, like just a couple of degrees on a towel or something, will recruit around 30% more of the intrinsic muscles of the foot.
Not the calf, bro. That come in handy.
But yeah, they were just like the really good things I found.
Yeah.
Stuff,
Nice.
which is easy to put into like this.
Absolutely, yeah. Oh, yeah. So if someone's worried about bunions, right? Obviously, we can't like undo bunions, obviously. But if someone wants to work on them, what I found is a good test is kind of putting your thumb between the big toe and the second toe, and then just get them to keep it separated.
Oh, yeah.
And people just start getting like cramps and so on. Yeah. So it's just something to work on.
Am I doing it?
Yeah, go on. Nice.
Their toes like that in general.
Yeah.
To do that. Yeah.
Nah, some Vivos, mate. This feels nice. Wow. Whoa. Oh, this one could do some work though. Go on. Yeah, there you go.
Look at me go, Ash.
Oh, but are you flexing these toes to compensate?
No, you're Ash.
It's good toes, thanks. Cheers, man. Cool. So, yeah, once you've done the assessment, obviously report findings, speak about milestones, and kind of what to expect if it's post-op, if it's pre-op, what pitfalls there can be, especially if they're trying to come off painkillers and so on, ADLs, what's been affected, kind of laying it out and assessing. So once you've kind of like laid things out for them, it makes it a lot more clear, obviously. Not trying to teach you how to suck eggs, obviously, but we obviously all do that here. Yes, rehab principles. So use objective measures if possible, just to kind of see where we're at. Kind of set like a timeline. Not necessarily a timeline because it can vary from injury to injury, but some sort of goals that you're kind of okay with so that you can kind of keep working off them. High chronic load before return to sport, which I didn't really think about, to be honest, because so just your like accumulated volume of things you're doing can be really important. So in one of the videos he was talking about acute to chronic load ratio, but he didn't explain how to work it out. So I think it's just a gauge of like what percent of what you're kind of totally doing and you're recovering from, how much you're improving by. Is it like 30%, 50%, whatever? Don't go above like 70%, especially if they're kind of early on.
70% of their previous crop load.
Yeah, previous week. So in terms of building on top of it.
Okay.
Because it's more skill based rather than, I guess, there is some sort of like neural issues and neural demand, but so just making sure that you're kind of building on top of what's going on, but not too quickly, obviously. Circuit training to keep up the cardio, because I've had that before where I've tried to come back from an injury, but I'm so unfit from not doing anything, then it kind of chasing your tail. And obviously, if your cardio is good, your recovery is going to be better, and maybe bring in some of the pathomechanics and so on into that. And just keeping active. A lot of athletes just prefer that. Assess the needs. Start simple. Educate about self-care. Like what can they do for themselves to help them feel better, so the area is not so sore and it's not been overloaded by training. Just in terms of explanation, this is something that that I've been sort of given a report of findings, but I'm explaining everything very thoroughly, but the patient doesn't care. They don't care if the facets are irritated, what muscles are irritated, or like their job is affecting it, whatever. And has anyone got any tips to figure out how much they want to know Or
I do. I try and, when I show them the anatomy,
yeah,
that if I see their eyes light up,
yeah,
then I'll tell them maybe a little bit more, but then kind of get them quite interested. I just look for them to start glazing over a little bit.
yeah,
Or for for
yeah,
that to become okay, you're just doing it out of routine. Now I'm actually really interested in what I'm saying.
yeah.
Then I might just cut it short a little bit.
Yeah, because he spoke about using like biomechanics, pain science, pathomechanics. I mean, you could be there for like at least 10 minutes explaining how an injury is what's happening.
Really interesting thing which I think I spoke to Elliot about.
Mhm.
It was specific to shoulder pain,
Oh, yeah.
Mhm.
but it was they compared pain education in terms of best practice
Mhm.
to anatomy specific pain education
Mhm.
to another side, pain neuroscience, and they found that pain education in terms of best practice had better outcomes than anatomy specific,
Mhm.
like neuroscience. So they said that effectively what they recommended was to say that something was not a sign of something severe underlying or the pain doesn't relate to a serious cause of damage. But adding anatomy on top of that would make it very minimal. So I've been trying to go more down that way.
So you're a bit more almost
Very
vague.
vague,
Yeah.
and say, I think it's some irritation with your whatever, but it's not a sign of anything serious underlying. And I found patients that responded to that. They said, oh, I was really hoping that's what you would say.
Oh, that's cool.
Compared to
Very good.
The anatomy and whatnot.
Yeah.
Yeah, that's a good point. Yeah, because obviously they say 80% of lower back pain is non-specific, so they can't find a specific cause.
So that reassurance as quickly as possible.
Yeah.
And some of them say, but what specifically people is, and then I'll show them.
Yeah.
But I've been trying to, as long as I do genuinely think it's not something, I'm trying to add a phrase similar to that effect.
Yeah. Oh, nice. Yeah. I've found that the word like sensitivity rather than like damage or maybe irritation or like sprain, because technically if you've got a positive Kemp's test, it's technically probably a sprain, a very minor grade 1, but it is just irritation. Like MCL, you can just irritate it. But if you say sprain, I think, oh, I've sprained my knee.
Permanent damage,
Yeah. But yeah, that's interesting. That I've definitely had that in. Yeah, thank you. Because yeah, I've had people just kind of literally tell me like, listen, I don't care, fix me, which is fine. Yeah, I know, but it's fine. Cut to the chase, sort of thing. Anyway, let's cut to the chase. Right, rehab principle. Yeah, maintaining workload without pain or setting sort of goals as to how much they're okay with. Something sort of Elliot's kind of spoken to me about in terms of how much pain are they okay with, how much they want to go through, and how much is stopping them from doing their daily things. So work around the injury rather than avoid. Yeah, post-op. So like rules of thumb are be honest about the pitfalls, the challenges, post-op sort of when it starts, re-injury rates, potentially, but that might cause some catastrophization. So I guess be careful with that, but depends on what kind of person is walking into the clinic, I suppose. Fair enough.
Interlude.
Should have done that in our little break. But yeah, a little cycle, like a reflective cycle. So reflective cycles have made me want to pull my hair out at uni, but now they're super important and I do it all the time. So listen, reflect, what's going on, try something and then pivot or repeat. So obviously, yeah, it is what it is. Kind of keep trying, letting them know it's kind of trial and error sometimes. So it's a handy little sort of pyramid here. Okay, so you've got acute 0 to 4 to 6 weeks, subacute 4 to 6 to 10 to 12, and then 12 to 20 kind of advanced S&C, just getting them to sort of being active and athletic, and then 20 plus getting return to sport. So obviously that'd be graded return to sport, but that's kind of what you're aiming for. But obviously, it depends on what's going on. If it's a little ankle sprain, it's their first one. It's going to be different to labrum tear. So yeah, these phrases are really like useful actually. So just damage control, put the fire out, and then be human again. So subacute would be human again. Do your ADLs. Like if it's like a school kid, can you get to the next class without any pain, where you're having to work around something? And then once you can do that and you haven't got too much pain, then learn to be an athlete again. So just general stuff, and then some just being a gymnast again. So some specific things to gymnastics or football or whatever. Yeah, that was just really nice to like kind of gauge where you're kind of being with someone's injury. Yeah, it's really helpful. So goals is just getting range of motion back, reducing pain. So reverse reflective inhibition is what it was called. Basically, use pumps. So if it's an ankle injury, kind of just pumping in a pain-free range. I think that's just reciprocal inhibition from what I gauge from it. But yeah.
So just getting the area, just pumping it, just moving it.
Yeah, just get some swelling out there, because because like the inflammatory soup is kind of in there. The swelling's there. I know, hilarious name in it. Yeah, you're kind of just pumping out there, so it can first of all renew. So the substance P, obviously the painful thing, isn't there so much or as long. So it gets them to feel like, oh, swelling's coming down now. Oh, it's gone back up, but it's not been too bad because it's coming back and forth. Yeah, educate, communicate. Start with sort of passive range of motion, then get them to obviously actively do it, and then resisted range of motion. I think this is where we can do the most, I suppose, in the rehab process, because you can help them get a bit more range of motion within limits, and then they can just maintain. They don't need to kind of start pushing, and it gives them someone to like go along with. So yeah, yeah. Assess and treat kinetic chain, so upstream, downstream, which is super important. So giving them sort of things to look at in terms of day-to-day things, so that it can work around the injury. So if it's a labrum issue, don't like turn the leg, lift the leg and come round. So just things to work around it. There's a bit of a message of kind of avoiding the pain, which is obviously important, but does that lead to catastrophizing? It's just swings and roundabouts, especially if we'll just take their attitude and how it goes, I suppose. So goals of phase 2. So going between isometrics to isotonics. Sorry. Yeah. And then, isometrics to, joint motion, and then to isotonics, kind of going back and forth. So seeing what works, and then just tell them, like, pick one. They're both like pretty much the same. They're like manageable. Tell them to pick one, and then they'll probably be happy with it. Set markers for response. So what he said was 3 out of 10 pain. It's not pain for more than a day. And I think it's daily. Yeah, no impacts on ADLs. Yeah, so just so they can be human again and do their like thing, like just like going to Nando's or something, so they're not in like crazy pain going to it. Linear periodization, so telling them, okay, just do a little bit more, and really drill home the idea of consistency. So when people come back and I've given them like say 3 exercises, they say, oh, it's been a really bad week, I've not been able to do them. And I say, oh, how many times have you been able to do your exercises? And they say, oh yeah, I've done them like 3-4 times. I say, great, just do that every week, because that way you can kind of manage that acute to chronic load and sort of build from there. That's what I found kind of like transfers over quite well. Kind of, yeah, meet them like what your CPD was about. Just kind of meet them where they're at, what's realistic, and just build on that. And what I say is kind of like, when you do them, bring your A game. Like each rep, say you're doing 10 reps, that rep is the only rep you're doing, and then do that again. So that focus is really important. So they're kind of really feel like they're doing something for it, rather than like, oh, I've got this chore to do, kind of going from there. This is going to be a lot of talking, I'm afraid. It's just talking about rehab stuff. Yeah, so mobility, then controlling and loading. So eccentrics, and then later down the line, obviously, plyometrics. Working on energy systems and keep up the cardio. So some good criteria here. Moving on to phase 3, which is sort of advanced S&C. No pain with the ADLs and exercise loading. Full pain-free passive and active range of motion. Getting wanted dose to exercise and progressing and keeping it challenging. So they're really having to bring that A game, so not getting bored, because yeah, if it's something they already do and they're very good at, it's going to be sort of boring, I guess. Minimal fear about progression. They like, ideally you want them to be hungry, so you want them to come in like, okay, give me something good so I can really attack it, rather than like, oh, I don't know, are you sure? Like, I don't know. And then you're having to prove to them like, look, you can do this. Then make it a bit harder, but do less of it, and then build from there. Yeah, like the whole medical system thing I said about, clearance from MD as appropriate. But in the UK, it's a lot tougher, so we have to use our clinical judgment there, going from there. But if it's like a severe surgery case, then you've got to just weigh up the options and go from there. Just see if they're happy with it, and just, yeah, build that sort of case with them. Okay, so markers for advanced rehab progression. Obviously, minimal pain, ADLs sweet. Okay, chronic workload is low. So that'll be a case of like, okay, there's a regional gymnast coming in and they're doing 3 exercises for 3 sets a week, 3 times. So that's going to be far lower than what they're doing. But then if you continue to add on to that via reps, sets, tempo, or load, then you're kind of gradually getting there. So here you can start building movement patterns. So what he spoke about was, okay, say this is heavy, okay? So say, I don't know, I've got a bit of a knee issue, okay? So I'm kind of coming back into it, but I'm nervous about squatting, okay? What I can do is kind of use a counterweight, so kind of get me to push my weight back and coming back up. You can use a TRX and then slowly kind of lower the box. So start with box squats. So what we were saying about being able to sort of absorb and load. Yeah, so if you just take that out in terms of that acceleration, so that deceleration, that acceleration, then yeah, it can kind of open up a lot of gates. Eccentric loading, pauses, anything really. Dynamic stability, which is something I never really thought about, to be honest. So that's kind of stabilizing yourself under motion. So that will be something like standing on one leg and then tapping 3 points, or maybe someone throws a ball at you, you tap here.
As well.
Sorry? Yeah. Yeah, my calf started feeling that straight away. Yeah, so kind of, yeah, like what we do so well here is kind of bridging the gap between where they need to be and where they are, and showing them, look, okay, you're using TRX now, okay, just use one of them, and then kind of build from there. So yeah, reassuring as per. Okay, so here, this is where we kind of build strength and power and sort of anaerobic capacity. So you can use sort of circuits, relatively heavy lifting. So I think it's on this slide. That's it, yeah. So load, higher reps with low load, or higher load with lower ROM and reps. So that, like, I don't know, say, yeah, gymnasts can handle, say, 60 kilos, but with like really good form, getting down to the bottom, coming up. Okay, maybe try and put 80 kilos on there and just do half a squat. So that will really improve their ability to sort of trust themselves, and obviously building the energy systems and so on. Cool. Speed work, pogo hops, skipping. So I totally forgot that gymnasts actually run. So obviously they have to like run for the round-offs and stuff, right? Yeah, I just saw it like, what? I thought it was just like, just do the bars or vault, whatever. So just some pogo hops, getting them ready, and then single leg, and then just some skips. So I initially thought like skips like this, obviously, but then you can kind of do like A skips, like.
Wait. Let me see how much.
Go Totus. But yeah, you can break the sprinting down into various parts, obviously. Actually, yeah, I'm going to get my hammer on. Okay, so obviously you're here, you're pulling, and then you're extending. So what you can do is, okay, right. So obviously, and then what you can do is really like dig that leg back and claw back. Woo.
Nice.
So yeah, so break it down. Yeah, so to help them sort of improve speed and ability to kind of push through kind of like inertia, I guess, getting them to be an athlete again. Like, wow, look, you can move quickly, you can move dynamically, you can like balance on one leg. Look, it's coming, like it's happening. Yeah, plyometric, so pogo hops, and then so you can use a progression of kind of on the spot, and then so just really low ones or really high ones, land and stick dynamically, and then just bound, and then land and stick, and then up to a box jump as well, because you want to make sure that you're working horizontally and vertically. I would imagine there's more hip extension in horizontal. Yeah. So yeah, it kind of works everything. Yeah, rebuild chronic load with gym work and home exercises. One thing I've noticed that from like a lot of the athletes I see here is some of them don't even go to like an actual sort of gym to kind of do extra stuff. So there's a massive thing missing in SNC, at least in America, according to Miss Tilly. I think Mister. Doesn't matter.
Doctor, I think.
Is it doctor?
I think physical therapists are doctors there.
Oh,
I think they're at doctor's level.
fair enough. Anyway. Yeah, anyway. According to him, there's a massive missing piece about strength and conditioning. It's more about, okay, let's just do really high reps. Just how long can you do this so you can handle that massive workload, rather than, okay, how much can you shift so that you can, each of those reps you do is powerful, dynamic, so you can, I don't know, get an extra foot off the floor or whatever you do. So yeah, so just educating about how important higher loads are and speed is would be quite cool. Quite cool. Wow, I'm running out of words. It would be nice. Yeah, weighted plyos be awesome. So return to sport requirements. So this is when they start frothing at the mouth, right? It's like, okay, come on, bring me in, coach. So no pain with advanced strength. So squats, hinges, split pelvis motions, single leg stuff. Yeah, dynamic stability, power work, full pain-free compounds, so they can kind of hit parallel on a squat, deadlift, and so on. Dose response with S&C and basic sport moves. So they're still practicing some of their stuff at home. Or what I found is really helpful with footballers, where a lot of the, I guess, we don't get like any like super like semi-pro people from what I've seen anyway. It's more normally like people that just play on the weekend, maybe train once a week. Just turn up to training. Just go, have a laugh, just be there, do your exercises so you're around that environment so you can start kind of just integrating back into it. But yeah, minimal fear again, and clearance if possible or appropriate. Okay, rebuilding patterns, like I said earlier. Okay, so with squat, like we went through, kind of use a counterbalance or a TRX, And then hinging, what you can do is either get a dowel rod, just kind of do that classic sort of practice that hinge, because some gymnasts might not have even lifted weights before. So we've got to make sure that kind of they're lifting sort of to the book and so on. But obviously when you're lifting heavy, you can go out the window, but whatever. Hip thrusts, not a fan, because it's not practicing that axial loading. Because what you might do is kind of do some kettlebell stuff, kettlebell swings, whatever. And then, so the progression he mentioned was, dowel rod, kettlebell deadlift, and then hip thrust. But I think what would be better would be good mornings, because that's still that hinge pattern, and that's getting them to handle more load. So say you've got like your body weight on here, which is like doing a pogo hop. So that will be a little bit more applicable, I think. And then deadlifts. Split position, which is really interesting. So using a TRX for a split squat. And then if you want to, let's get this right. So if you want to attack posterior hip more, okay, so you want to elevate the front leg. Okay, this is going to be super exaggerated. 3 hours later. Okay, so obviously I'm doing split squats, fine and dandy. So pick a weight that you want them to work to and go to the next one. You kind of want to go here. That's super high. Oh yeah. Okay, so yeah, proves the point, doesn't it? Okay, so you're kind of really stretching that posterior leg, so posterior hip, and coming down. Or what you could do is obviously Bulgarian squat, and kind of really targeting the knees. Obviously, this whole idea of you can lean forwards and do your glutes and da-da-da-da. So find what fits best and to what they have available as well. Thank you for listening. That was sort of an explanation on how to rehab from a lower limb injury for gymnastics specifically, but this can be applied across all sports. But yeah, thank you. Hope it helps.